Welcome back. Today, we are diving deep into an explainer on some of the absolute most complex, highly tested scenarios you're going to face on the CPC exam. We're conquering respiratory and cardiovascular case studies, decoding the exact rules you need to lock down for certification. And hey, before we jump into it, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Here's our agenda for today. We're tackling high-yield, boss-level scenarios. First up, respiratory endoscopy bundling rules. Then pacemaker component coding rules. After that, cabbage combination coding rules. Next, coronary interventions hierarchy rules. And finally, we'll wrap up with a visual summary cheat sheet. Let's get into it. Section 1. Respiratory endoscopy bundling rules. Okay, let's look at two distinct scenarios. In scenario A, we've got functional endoscopic sinus surgery, FES, where a sinus endoscopy is followed by a maxillary antrostomy and an ethmoidectomy. Now, scenario B is a respiratory case where we're comparing a diagnostic bronchoscopy, which is just an inspection, right, versus a surgical bronchoscopy that actually includes a biopsy. The big dilemma in both of these systems is exactly the same. How do we code it when the physician inspects first and then takes a surgical action in the exact same session? Well, the answer lies in our bundling golden rule. Diagnostic endoscopy is literally always bundled into a surgical endoscopy if it's performed in the same anatomical area. Basically, the surgical code completely absorbs the diagnostic one. So whether it's a sinus endoscopy that turns into an enterostomy or maybe a bronchoscopy that leads to a biopsy, that initial phase of just looking around is inherently included. Don't make the mistake of unbundling those. Moving right along to Section 2, pacemaker component coding rules. So, pacemaker codes are structured entirely based on the hardware. It's like a giant puzzle. A single-chamber system, which uses codes 33206 or 33207, involves inserting a pulse generator and just one transvenous lead, either atrial or ventricular. On the flip side, a dual-chamber system, that's code 33208, requires the generator plus two leads, one for the atrium and one for the ventricle. Now, listen closely, because the CPC exam will absolutely try to trick you here. You have to read the operative note like a detective. Ask yourself, are you coding for a complete system insertion, or did the surgeon only replace the generator? Or wait, maybe they just repositioned a single lead. Device work has multiple moving parts, so you can never, ever guess based on just a partial description. Code exactly what was inserted, replaced, or removed. Nothing more, nothing less. All right, Section 3, CABG combination coding rules. Let's break down a classic exam scenario. The surgeon performs a CABG using the internal mammary artery, which is an arterial graft, to the LAD. And they also use two saphenous vein grafts. Because they used an arterial graft, your primary base code is going to be 33533 for that one arterial graft. Then, because those venous grafts were done in combination with the arterial graft, you stack on the venous add-on code. That's going to be plus 33518, which covers those two venous grafts combined. And here is the major exam trap you've got to avoid. The primary venous graft codes 33510 through 33516 are only used when venous grafts are used exclusively, like exclusively. If there is even one single arterial graft in the mix, that arterial code takes the primary spot for sure. Then your venous grafts must be reported using those add-on codes we just talked about. It catches so many coders off guard, so don't let it be you. Section 4. Coronary interventions hierarchy rules. So what happens when multiple interventions happen in the same exact vessel? Well, CPT guidelines enforce a strict descending hierarchy. It goes like this. Stent placement is the highest priority, period. Atherectomy is medium priority, and angioplasty, or PTCA, is the lowest priority. So if a surgeon performs an angioplasty to open up a vessel and then places a stent right in that same vessel, the stent code totally absorbs the angioplasty. The highest level service always wins out. But keep this in mind. This hierarchy applies per major coronary artery. Think of the heart as having three main highways: the left anterior descending, or LAD, the left circumflex, or LCX, and the right coronary artery, or RCA. Now, if you put a stent in the LAD and do an angioplasty in the RCA, guess what? Those are distinct vessels. So in that specific case, you'd report separate codes for each vessel. Distinct vessels mean separate codes. Same vessel means hierarchy rules apply. Finally, Section 5, our visual summary cheat sheet. All right, grab a screenshot of this summary table right now before your exam, because it locks in all the core golden rules we just covered. For endoscopy, surgical always includes diagnostic in the same area. For pacemakers, carefully code components, leads versus the generator. For CABG, the arterial is your primary code and venous acts as an add-on. And for PCIs, remember that strict hierarchy. Stent over atherectomy over angioplasty per major vessel. Ready for part 57? Next time, we're going to decode the complexities of the digestive and urinary systems, tackling things like hernias, GI endoscopies, and biopsies. It's going to be a good one. Until then, consider this. In medical coding, a single misunderstood guideline doesn't just change a billing code, right? It literally changes the entire clinical narrative on the patient's record. So what are you doing today to ensure your narrative is perfectly accurate? See you in the next explainer.